Good afternoon, and I will briefly talk about the approach to the more common forms of posterior uveitis. So I'll start with the infectious forms of posterior uveitis, mostly because, see, these are infections, so specific treatment is available in most of these cases. And these are not only rapidly sight-threatening, they may also in many cases be life-threatening. They may indicate underlying immunodeficiency. And most importantly, treating these cases with steroids alone is dangerous. It worsens the situation. So we should know which is infectious, what is non-infectious. So going with the more common types, first, we need to, most of posterior uveitis is again pattern recognition. It's very visual. You need to look at a lot of pictures and you will figure out what these entities are. So first, look at the level of involvement. Are we looking at retinitis, retinochoroiditis, or choroiditis? Then the pattern of involvement, is it focal, multifocal, diffuse, immunosuppressed, or an immunocompromised patient? Then are we dealing with a posterior pole involvement, which has its own issues in terms of how rapidly the vision deteriorates, or peripheral involvement? Now this is what a choroidal lesion looks like. It's ill-defined. It's well within the choroid. The retinal vessels overlying it are undisturbed. There is no vitreous involvement. Now this has more of a retinal and choroidal involvement. There is some amount of overlying vitritis. This is your typical retinochoroiditis. And this is purely retinitis. You can just see that this full thickness retinal necrosis is a sharply demarcated area here between the retina and the involved retina and the uninvolved retina. Now we'll go ahead with toxoplasma infections in the eye. This is a typical congenital toxoplasma scar, which is punched out, inactive. We see many children with this. We just need to follow up these patients. They can have reactivations, so they should be aware of it, have annual examinations, and document the fundus photograph so that you know the size of the lesion and everything. Now, toxoplasma, the acquired toxoplasma infections can start off with sometimes without any peripheral scar or any pigmented scar. There again, dense white, yellow retinochoroidal lesions with some amount of overlying vitritis. Sometimes you can see these lesions starting at the edge of a pigmented scar. So then you have already got a big clue that this is most likely toxoplasma infection. Go ahead with treating for toxoplasma. Some of these patients have anterior uveitis with raised intraocular pressure, which is why it's very important in all cases of anterior uveitis take a good look at the fundus. Sometimes there's just one focus somewhere in the periphery, and if you miss that and only treat the anterior uveitis, you're never going to have a resolution of the problem. Now we have a wide variety of antibiotics to treat toxoplasma infections, and in most immunocompetent patients you need a combination of at least 2 antibiotics along with systemic steroids. Now there's no fixed duration of treatment. Again, it depends on the size of the lesion and the severity of the vitritis and how long it's going to take to heal. So the very minimum seems to be around 4 weeks, but we've had people who are treated up to 6 months. And what is important is to continue the antibiotics. Start the antibiotics before the steroids are started, and continue the antibiotics till after the need for steroids is over and the lesion has completely resolved. And like in anything else, you can have, even in inactive toxoplasma scars, you can develop a choroidal neovascular membrane at the edge of the scar. If it's subfoveal, nowadays treating with avastin lucentis, as may be the case, we often provide anti-toxoplasma cover for the duration of treatment, because not for anything else, we know that the addition of the oral steroids also helps with regression of lesions, especially when they are subfoveal and when we have very limited options. For extrafoveal lesions, it's convenient to do a laser. They do very well with or without anti-toxoplasma treatment. Now in immunocompromised patients, now in HIV the kind of toxoplasma that you see is often fairly extensive. There can be large multifocal areas of retinal necrosis with a lot of vitritis. And in the old days, before antiretroviral therapy, it used to be easier to differentiate between CMV retinitis and toxoplasma retinochoroiditis. But nowadays, with people being partially treated on antiretroviral therapy, the occurrence of a lot of immune recovery vitritis, it may not be that easy to differentiate between CMV and toxoplasma retinochoroiditis. But once you're sure it's toxoplasma, start the antibiotics in any case pretty much immediately. Then, if the patient's previously undiagnosed, and then go ahead with assessing the CD4 level, starting heart, or if they're already on heart, reassess the therapy. They may need a change of therapy. Systemic steroids may be required depending on how much of vitreous involvement is involved, how much of immune recovery component is there. Then we move on to acute retinal necrosis, which can be seen both in healthy patients and in immunocompromised patients. And this is purely it's caused by viruses, most commonly from the herpes group of virus. So we do have specific treatment available. Now this is your classic case of acute retinal necrosis. Peripheral retinal necrosis, full thickness retinal necrosis, a sharply demarcated line between the uninvolved retina and the involved retina. There is vasculitis also in this, in patients with acute retinal necrosis. Again, these patients often have anterior uveitis with raised intraocular pressure. And if you may not see patients with such extensive necrosis, you may be seeing milder cases. So again, dilate, see the fundus, see that we're not missing a patch of retinitis. Now, if it's very typical, the diagnosis is clinical, we really don't need any more investigations, we can go ahead with treatment. But again, sometimes you don't have extensive necrosis, you just one patch of retinitis and you are still not sure whether we are dealing with toxoplasma or a viral retinitis, because treatment really differs between the two things. So in those cases we might decide to go ahead with aqueous aspirate to decide on treatment. Now treatment usually involves a course of intravenous acyclovir followed by oral acyclovir. But with smaller degrees and less severe retinitis, oral valacyclovir has been a great help to all of us, because it avoids the entire cycle of admitting the patient, having an intravenous injection for days, and it's relatively inexpensive. 1 gram about 4 times daily initially, and then step down depending on treatment, on the response to treatment. Now oral steroids are also required, which we usually start pretty much after about a day of acyclovir. Now about the role of laser photocoagulation in acute retinal necrosis, it's still debatable. If it's a limited patch of retinitis, we often observe these cases because very often these patients are young patients, and despite the fact that we have barraged them, they still go on to develop a retinal detachment, mostly because they don't have PVD, and the very fact that they're having vitreous inflammation and we're going ahead and doing laser photocoagulation sometimes induces really acute PVD and massive retinal detachment with huge breaks in the periphery, and then of course we have to hand over to the VR surgeons. But milder forms of retinitis can be watched, and we don't often laser every case of viral retinitis. Then now in the post-heart era, we see a lot less CMV retinitis than we used to in the past, but it generally occurs only when the CD4 count is below 100 cells. So in the non-HIV positive patients, you can also see CMV retinitis in people with malignancies who are either some of them post-chemotherapy, post-transplant patients. So look for a source of immunodeficiency whenever you see CMV retinitis. Now CMV retinitis can be both peripheral or posterior pole. This classic thick, full thickness retinitis with a lot of hemorrhages. And in the peripheral forms of the retinitis, that's where you tend to see most of the breaks developing. If you have a posterior pole CMV retinitis, you really don't have to worry about rhegmatogenous detachments. But in peripheral retinitis, you do have this. Now, first assess whether the patient is HIV positive or not HIV positive. If HIV positive and not treated, they need to be started on antiretroviral therapy as soon as possible, because just by building up the CD4 levels, the CMV retinitis will come down. You cannot treat without antiretroviral therapy. If they're already on antiretroviral therapy, then it may mean that, and the CD4 counts are low, then it means that they have developed drug resistance to 1 or 2 of the drugs. You have to sit with your physicians, work out out a different combination of antiretroviral drugs. If their systemic medication is not sorted out, it's very difficult to treat the CMV retinitis. Again, in non-HIV positive patients, like the transplant patients, you can coordinate with them and find out whether their medical immunosuppression, the post-transplant drugs can be reduced a little bit till we can get the disease under control. But the non-HIV positive patients tend to do quite well, so sometimes it may not be required, the reduction in drugs may not be required. Again, treatment can be with IV ganciclovir and with oral ganciclovir. With the availability of oral valganciclovir, a lot of us are shifting to oral valganciclovir if the patient can afford it. It avoids the risk of the entire intravenous ganciclovir, the risk of an indwelling catheter. And but with oral valganciclovir, the patient should not be very ill. I mean, the bioavailability of the drug should be possible. They should be able to take the drug orally. Otherwise, it is intravenous ganciclovir, and also in severe cases, it is intravenous ganciclovir. You can supplement with intravitreal ganciclovir in patients, and very often we do this combination of try with some form of start antiretroviral therapy, then get oral or intravenous ganciclovir, and then keep supplementing with little bits of intravitreal ganciclovir, because therapy is really expensive, and they are already spending on antiretroviral therapy. The ganciclovir, in addition, can pose a lot of financial problems for the patients. The intravitreal implant is practically not used anywhere in India, so I'm not really going to discuss this at the moment. Now, well-treated CMV retinitis regresses very neatly, especially posterior pole CMV retinitis, and vision can be preserved absolutely, 6 and 6 vision. Again, it can be, the healing is very neat and poses no major problems. They need to be on follow-up. But if it's advanced, there's a lot of optic atrophy. The vessels are sclerosed. Of course, we have a lot of patients who have lost PL. And we can't forget the fact that immune recovery uveitis has become part and parcel of every single HIV positive patient's treatment. Now, it never used to be in the past somehow, but now once the patient's immune system has started to recover, there is a significant amount of vitritis, disc edema, tractional detachment, CME. So we are finding that we have to supplement with systemic steroids more often now than we used to in the past. We would prefer to use local steroids, depending on the kind of immune recovery uveitis. If it's anterior, it's topical, little bit of vitritis, periocular steroid. And then if it's systemic, we have to discuss with the patient's primary physician whether or not we can add a systemic steroid. Now, progressive outer retinal necrosis is extremely rare. Just widespread retinal necrosis, which is between blood vessels. There's always a clear space between the blood vessels, but it's very difficult to treat despite massive amounts of acyclovir. It's caused again by the herpes group of virus. Then you can see other kinds of retinitis. Now, this was a patient who was immunocompetent, came with what is clearly retinitis. It does not look like toxoplasma. All tests were negative. We gave a course of antiviral therapy, empirical, along with systemic steroids. You could see that the areas of retinal necrosis kind of spread out and eventually kind of reached a certain, and then it scarred off very neatly, and patient has 6/9 and 6 vision, but we don't have an idea what the cause is. Now, it could be another virus, it could be atypical mycobacteria. These are other causes I'm saying, but in this particular case it was probably some other virus. Syphilis, fungal infections are known to cause retinitis. Rarely, primary intraocular lymphoma can cause a focus of retinitis, and Behçet syndrome, and rarely sarcoidosis. These have to be just kept in mind in atypical causes. Then we have children with, classic, this is posterior pole toxocara, and it's peripheral toxocara granuloma. There's nothing much that we need to do except with short courses of oral steroids in case of significant vitritis. Then if the posterior pole, the structural issues can be treated with vitreoretinal surgery, then we need to go ahead with the treatment. Now, this was a patient with focal choroiditis. So this is the debate about whether this is sarcoid or TB. I'm not going to get into it. This patient had come to us after 1 year of ATT. He had retroperitoneal lymph nodes. A biopsy had been already taken. The biopsy showed granulomatous inflammation, but not classically, no necrosis. And there was no AFB on any of the sort of slides. He'd received a whole year of ATT. He was diabetic, sugars were 500. So now at this point in time, it's very difficult to decide, and his liver function tests were abnormal. So we sit with the physicians, go through the entire TB workup again, go through all the imaging modalities, get the sugars under control. Then we have to start initially with a course of oral steroids, but these patients have to be shifted onto immunosuppressive therapy pretty fast. So we start on azathioprine, which takes about a month to start acting. So the patient was eventually treated for about a year with a low dose of systemic steroids, and 3 years with azathioprine. In between there were recurrences, but they all settled down, and currently he's 6'9" and 6 with mild cataractus changes, no recurrences, only on topical steroids and non-steroidal agents. Now this is a subretinal abscess, which was due to tuberculosis. Pretty obvious, I'm saying. I don't think I have time for the white dot syndromes, but anyway, briefly, APMPP will be. Can I, Suchitra?
Yeah, ma'am. Please continue.
Slightly mutes has very, very subtle, small, tiny white dots. But little larger lesions are APMPP. Again, both have viral prodrome and will settle down without treatment. But atypical forms of APMPP, or what is called amphigenous choroiditis, always require treatment. Now, the poor prognostic factors being if the fovea is involved, older patients, if it's unilateral disease, anything which is atypical, just treat as probably presumed for forms of amphigenous or multifocal choroiditis, whatever we want to see. This is classic serpiginous choroiditis. Very flat, contiguous lesions with an active border. And current protocol is basically to investigate for tuberculosis with whatever methods you have, and if it's warranted, give ATT, and you will always have to also treat with steroids, sometimes possibly with immunosuppressive treatment, depending on the response in individual cases. In atypical cases, again, we're not really calling it serpiginous choroiditis, and we don't have time for that discussion right now. Now, multifocal choroiditis with panuveitis exists as a separate autoimmune entity, but many infectious diseases can cause multifocal choroiditis also. So we always investigate for tuberculosis, syphilis, toxoplasma, then also do a workup for sarcoidosis and collagen vascular disease in multifocal choroiditis before we go ahead with treating with immunosuppressive agents. And depending on the case, it can be fairly long, drawn out and severe, with a lot of secondary problems like glaucoma and cataract coming up, all of which you will have to deal with as and when they occur. And of course, many patients, it resolves on its own. There are patients who just come who have no knowledge that they've even had multifocal choroiditis, but an extensively scarred retina, but this patient never needed treatment. So basically, it's just important to differentiate between the infectious and the non-infectious diseases. The diagnosis is clinical in most types. Laboratory investigations are useful when we want to try and differentiate infectious diseases or underlying immunodeficiency. And establishing the right diagnosis right in the beginning goes a long way to eventually having a successful outcome in posterior uveitis. Thank you very much.